Welcome back to the Todd Durkin Impact Show, the podcast dedicated to lighting you up with inspiration, motivating you to be better in all areas of your life, and igniting action inside of you so that you can ultimately create more impact in this world that so desperately needs you. On every Impact Show, we dive into mindset, health set, leadership, and something personal so that I can coach you to be the very best version of yourself. With that, it's time to dive into today's Impact Show episode. Yoo-hoo! Hey, yeah, you know who it is. That's right. Hey, high performers, trainers, coaches, life coaches, and all high performers. What's up? Todd Durkin here, and I want to invite you to something very special. Y'all been hearing for how long now about this Montana retreat? Man, I need to go to Montana. Well, it's already booked, November 13th to the 16th, this coming 2025, and I'd love to see you in the room because that's where the magic happens. But right now, you have a very special offer if you'd like to take advantage of this offer. If you join my Todd Durkin High Performance Mastermind group, that's right, if you join it, and you join it by May 31st, you're going to get that retreat for completely free. Now, listen, $999 is a steal. It's a great value at $1,000. But if you join now, the mastermind group, you get that $1,000 gift completely free. So join the Todd Durkin High Performance Mastermind group today. It's where leaders grow stronger together. You're going to want to be in the room. Right now, when you join, you get the 3-day retreat in Whitefish, Montana, completely free. You did not hear me wrong. That is correct. Simply visit toddurkin.com/TDMastermind. That's toddurkin.com/TDMastermind and book your free strategy call today. And you're going to start benefiting today, and you're going to get the retreat for free come November. I can't wait to see you inside the mastermind group and then in gorgeous Whitefish, Montana this November. Peace, God bless. I'll see you on the inside. Welcome back to another episode of the Todd Durkin Impact Show. And boy, oh boy, am I fired up today, and my heart is literally on fire. My heart is on fire because I have a cardiologist in the house today. Yep, I have Dr. Milind Parikh in the house. And let me tell you what, he is a preventative cardiologist. You're like, what's a preventative cardiologist? You're going to hear about it all today. And I must say, several months ago, December 24, January 25, I got tested and had a CT scan of my heart with a complete test of not only the calcium score, but also the plaque. And you're gonna hear all about why plaque is important and this. We're gonna talk shop. We're gonna go deep on this. But take a listen to Dr. Parikh's background because it is going to wow you today. And I promise you, if you're out there doing cardiovascular, more cardio, less lardio, cardio means heart. And let's get some working out going while you listen to today's show. Dr. Parikh is a cardiovascular disease specialist and dedicated preventative cardiologist, passionate about protecting patients from the life-altering effects of heart disease, the number one killer in America. With a career rooted in evidence-based medicine and cutting-edge diagnostics, Dr. Parikh has made it his life's mission, to identify cardiovascular risks early and intervene before heart attacks occur. His extensive training and multiple board certifications in cardiovascular disease, cardiac CT, echocardiography, and nuclear cardiology reflect his commitment to providing comprehensive state-of-the-art care for his patients. He's also completed a certification in cardio rehabilitation disease from the American Academy of Anti-Aging Medicine. Let me just tell you, he's got more certifications than most doctors have. It's incredible to see. Dr. Parikh has a unique approach to preventative cardiology, blending his latest advances in diagnostic techniques with a personalized and integrative treatment philosophy. And lastly, beyond clinical work, Dr. Parikh is actively involved in clinical trials exploring new frontiers in cardiovascular prevention and care. He serves as the current director of the Cardiac CT and Preventative Cardiology at Image One, where I got my heart scanned, and the Cardiovascular Institute of San Diego. Additionally, Dr. Parikh is a sought-after speaker, delivering engaging presentations to physicians and patients on various topics related to preventative cardiology. Passionate about education collaboration, Dr. Parikh works closely with his patients to implement meaningful lifestyle changes, optimize treatments, and leverage emerging technologies to achieve lasting results. My friends, I'm going to tell you this right now. Buckle up your chin straps. Get ready. Dr. Parikh is in the house. Let's go there right now. Let me tell you what, you're in for a treat right now. I've got Dr. Parikh in the house. Dr. Parikh, welcome to the show.
Hey, thank you. Thank you so much for having me, Todd. Very much appreciate it and excited to be here.
I'm so excited to have you here and share with all of our loyal podcast listeners the great things, the impactful things that you're doing. Gosh, not just in your business, but in this world. Like, this is an area that I'm so passionate about, heart health.
Yes.
As mentioned, if you've been following for any length of time, when I was 20 years old, my father died of a heart attack. He was just 58 years old. And I'm like, I don't want to be a stat like him. And man, just getting a few years away from when he passed. When we met in 2024 and you told me what you do, I'm like, we need to connect. I need to be tested for all the great things. So, by the way, how did I come out? Let's share with our people. Like, what do you think? Like, am I going to make it a few years or what?
You got plenty of years, Todd. I think you're doing very well. I mean, I think, as you know, because you have family history, it's maybe not perfect, but because we caught it early, there's so much we can do about it, and so much we can actually, do to stop any heart attacks from happening or progression from happening.
Share what I actually received. Like, what was the actual test? Because, guys, I didn't have any symptoms or pains of a heart attack. I didn't have a heart attack.
Yeah.
And you don't have to have a heart attack to do something about it. That's when we met. But share with our listeners what the actual test I received was. And I want to dive into it later on in the show as well.
Yeah. Well, I think that's a wonderful point, Todd, because I think we think about heart disease in like a way where you don't have any problems or any issues until you have a heart attack.
Right.
And that's like traditionally, like right now in cardiology, the way that we practice is like, you're fine. Oh, you have high cholesterol, you might have diabetes, but you don't have heart disease until you have a heart attack.
Yep.
Once you have a heart attack or a stent, now you have heart disease and things like that. But what you had is a test to look for the plaque buildup in the heart that causes heart attacks.
Yep.
And we call that coronary artery disease or atherosclerotic plaque in the heart. Okay? And once you are diagnosed with coronary artery disease, now we can actually understand where you're at and what your risk really is of having a heart attack. And it can actually treat you much better because of that. And so you had a coronary CT scan pretty much and a calcium score. And an AI plaque analysis on top of that.
AI infused. It's everywhere.
In medicine, I think AI is going to actually help quite a bit. It's going to help us progress quite a bit and do things and see things and do things that we've never really been able to do.
Yeah.
So, I mean, you kind of got the top of the line, the best test, really the best test that's out there to date.
Yeah, CT scan with a plaque score, looked at, the calcium score as well.
Yeah.
We got a complete analysis. And I think I just wanted the peace of mind that I don't have a problem, which I don't have a problem, but I'll share my whole 21-step plan later on in the show, like all the things I do.
Yeah.
But, one of the things that when we met that really interested me about you, you're a quadruple board certified physician. And I love as a preventative cardiologist. What does that mean, a preventative cardiologist? I had not heard of that name. I hear cardiologist, you got a heart issue, you got some type of a problem. Well, you're on the preventative side of things. Right. Talk about that.
Well, I mean, I think it's kind of a new and emerging field, to be honest, because for a long time, our prevention strategies have been not as effective as we would have liked them to be.
Yep.
It's heart disease, despite all the progression of medication, stents, all these things, it continues to be the number one killer in the United States, more than all cancers combined, right? I mean,
so heart disease, then cancer,
and then cancer, and that's and I'm saying all cancers. So like breast, colon, like everything all put together.
Cancer combined,
it kills more people than all cancers combined. So So it still continues to be the number one despite all the advances and progression we've made. And I think a big reason for that is because we haven't really identified the correct patients that would benefit from prevention, and really honed in on what is it that's actually causing the heart attacks, And I think a test like this, like what you had done, can actually, if you interpret that properly, get it done properly, interpret it properly, and get the correct treatment protocol based on what's actually, what those findings are, can actually really save everyone from having a heart attack.
Yeah. I've always said, as a person, you got to quarterback your own health. You got to take action before there's a problem. I think in our society, many times, if we wait, there's an issue with anything, then we go to the doctor. Hey, doc, I'm having pains or whatever it may be. And then fortunately, we have great doctors in the States that can take care of things. But when you look at preventative, it's before you have any symptoms, before you have anything, you're like, hey, I want to get ahead of the curve. How did you get into the preventative side of cardiology?
That's a funny story. So I actually, I did all my cardiology training, fellowship, got all these, like you said, board certifications and all that stuff. And it was funny. I started practicing in my practice, and I was like, 2-3 months in, actually. And I was like, man, what am I doing here? Like, honestly, people, I see a patient, they've had a heart attack, and then I put them on medications, and then they have another heart attack, and then they come back and put them on more medications and they have another heart attack. It's just it's just this consistent cycle of what am I doing? I'm just prescribing medications over and over again. Patients, the system today, the traditional medical system doesn't really allow for you to work with patients on diet and exercise and getting to the root cause of the problem and really kind of figuring out what's causing these heart attacks and things like that. And so, there's so much. I mean, I always say, 95% of heart attacks can be prevented, honestly.
95?
Yeah. 95% of heart attacks can be prevented, and even the American Heart Association says that, it's not even just me saying that. It's just, we are not doing good at identifying those patients that are really at risk. And then on top of that, we are not doing a good job. I mean, it's a disease, it's a chronic disease, plaque buildup and heart attacks and things like that is a chronic disease that is typically caused by our lifestyle. And our lifestyle is filled of stress, poor diets, sedentary lifestyles and things like that. And all of these things contribute. Stress, we know that for a long time, that people who are more stressed have increased risk of heart attack, right? All these issues, people's lifestyle is such that we just are, not really getting to the root of the problem.
They'll react.
Yeah.
So you talked about in January here, 25, when I saw you, there was 4 pillars of health. Yeah. And it was a really fascinating conversation because as a cardiologist, I was expecting to come in, get your heart tested and, get the results, the analysis, and you're out. But, you really addressed very comprehensively the 4 pillars. You talked about diet, well, Todd, you don't need help with your diet. I'm like, yeah, I do, doc. Exercise, the sleep and the stress, right?
Yeah.
And those you said those are the 4 pillars,
right?
To a healthy heart and good health.
Yeah, and I think and we all talk about. I think everyone knows diet and exercise.
Yeah,
I mean, those are the 2 most focused on things, right? Sleep, people are starting to become more aware that sleep is important, sleep hygiene is important, and that can, poor sleep can lead to more issues, such, blood pressure issues, insulin resistance, and all these different things that occur. And then stress, it's not just stress. I call it's our mental health overall. I mean, I think stress is for heart disease and heart attacks. I mean, we know for years and years and years, we've known this. Men who are stressed have increased risk of heart attacks. It's an independent risk factor. It's not even it's confounded by all these things. Independently, we know that stress. So it's I always say, think about that. Your mental, whatever's going on in your head is causing you to have plaque rupture in your heart. How is that possible? It's there. We know that correlation is there. We just are not have Western medicine's kind of hasn't really acknowledged it as much because we don't have a pill for it.
Yeah.
Probably.
Yeah.
Like that's typically like a lot of times.
So you're devoting your efforts to really prevent heart attacks by looking at the analysis and the tests and all. I believe I shared this with you. I know I shared this with you in January, but if you're a long-time listener to this show, you've probably heard me mention this a couple different times. But if you're a newbie listening to the show here in 2025, you probably have not heard me share this. But I shared it with Dr. Parikh in January. During the pandemic, I was exhausted, burnt out, fatigued. Naturally, there's something called the pandemic that I wasn't sleeping. So I go to the doc, won't mention any names, and I said, man, doc, something's off. Something's wrong. And I'm exhausted. I'm not sleeping, everything. And the doctor had said, you're stressed. You're really stressed. I'm like, of course I'm stressed. I'm trying to save my gym. I'm trying to save every other gym. There's something called the pandemic. Yeah. And he's like, you got to reduce stress. I'm like, well, great. I could have answered that myself. Yeah. But the truth of the matter is, and it wasn't until I met with Gabrielle Lyon, I told you this, met with Gabrielle Lyon, another doctor, and she said, you got sleep apnea. I'm like, sleep apnea? What? Like sleep apnea? I've heard of that. But that's for old guys. I don't have sleep apnea. And, I'm not overweight, I'm not obese or like that. And she said, no, you have sleep apnea. I'm telling you, you have a 17.5-inch neck. She looked at my ear. She looked at my tongue. And she's like, I'm telling you, go get tested. I came back to San Diego. I got tested. And my doc said, you have sleep apnea. Matter of fact, you're stopped breathing 120 times that night that you got tested in the 6 hours and 10 minutes. I'm like, wait, I stopped breathing 120 times in 6 hours and 10 minutes. Doc, when I say my life flashed before my eyes and I did my research, sleep apnea is called the silent killer. Yeah. My father passed away of a heart attack at age 58. I know he has sleep apnea. Now, sleep apnea didn't come out until 1993. He died in 92. Yeah. For 5 years, I wasn't sleeping. It was attributed, even from a doctor I had seen, you're just exhausted, you're burnt out, you're stressed. Never had been tested for sleep apnea. Wow. Now, I don't miss a night without my CPAP. I'm dialed in. I feel like $1 million now, because I got my health back. But no doc, I hadn't been even asked, let's get you tested.
Wow, that's incredible. I mean, I think it just goes to show how much I think you, luckily, since you are so proactive about your health, and you're proactive about getting things done for yourself, that you can prevent a lot. I mean, like you had this problem for so long.
Well, here's the problem. Yeah. I would have had a heart attack at some point. Yeah. My heart says, no, thank you. Here's what would have happened. I told my Melanie this, my wife. I would have died of a heart attack, and guess what happens? He died of a heart attack. Yeah. No, it was sleep apnea, the underlying cause. They call it the silent killer. Yeah. Sleep apnea stressed the heart so much that I stopped breathing 120 times. The doctor who I work with said, imagine going in your pool with a brick over your head and tread water for 6 hours and 10 minutes, the length of time you slept last night. Get out and tell me how you feel.
My God.
For the first time in 5 years, Doc, I was like, that's exactly how I feel. For years. I'm like, so once I got treated, I'm like, thank God. I say that because part of what why I'm sharing that, by the way, with Dr. Parikh here is because, man, ladies, if you're exhausted, burnt out, you're not sleeping well, get tested, because I'm telling you, you don't want sleep apnea, because you can get all the exercise in the world you did, because of course I would suck it up and take caffeine. Like, I'm getting my workouts in, I'm eating good. Doesn't matter. If you're not sleeping, you're dead.
There's a great saying I like to say: "It's test, not guess." Why are we guessing? Amen. There's very easy tests to do. Yeah. It's very simple, And now that oh my God, you feel 100 times better, and you've eliminated that underlying cause of what's going to cause you to have high blood pressure, which will then cause plaque buildup in the heart, which will then cause you to have a heart attack.
That's exactly it.
Different things.
The tie-in.
Yes.
The reason why I'm sharing that, guys, is because there's a tie to the heart.
Oh yeah.
Right. I never I'm just exhausted.
Oh, for sure.
I'm just stressed out. My doctor said I'm just stressed. Well, no fake. But there was an underlying issue that would have affected my heart to the point where I'd have a heart attack, die a heart attack. Hey, Todd was a good guy, but he died of a heart attack. Yeah, because I had sleep apnea. It was never tested. now it's tested. Now I know. So now I'm back to feeling like me again. So I'm so passionate about this topic, and because of my father's history, now my history, and obviously we've got 3 kids. So same thing. Tell me the difference between like your approach and the traditional approach when it comes to preventing heart attacks. How do you vary from traditional?
Yeah, I mean, I call this new age of personalized preventative cardiology, because we really are moving towards that. So I think the traditional approach, has been that, well, let's check your cholesterol markers.
Yeah.
Let's check your blood sugar. Let's check, for different risk factors, your inflammation markers and things like that, right? And you check all these different things, and then you decide, okay, you are at increased risk of having a heart attack, based on your blood pressure, based on your cholesterol, based on this, or you're at, low risk of having a heart attack. The problem with this approach is that almost 70 to 75% of people that have heart attacks have normal cholesterol levels. I mean, and so you're missing a whole lot. 50% of people, that have a heart attack have no symptoms before their heart attack. And 75% of the lesions that we see that cause heart attacks in the heart are actually caused by mild narrowing. So they're missed on stress testing. So this traditional approach, like when you've probably, many of you have heard this story, and I've heard this story over and over again in my practice. It's like, patient comes to me, they said, I had a stress test done and I was told everything was good. And then a few weeks later, or a month later, I had a heart attack. Or I had a patient literally had a stress test on a Thursday, and then on a Tuesday told me he had a heart attack, And then when I saw him in clinic, I saw him actually after his heart attack, a couple years after he came to me and things like that. But, he was like, we actually ended up talking about coronary CT and things like that, and what we can do and detect early and things. And he's like, man, I wish I had that way before. I wish I had that.
When do you typically advise people to start getting tested?
Yeah. So I think I'm going to go into that, and I think I want to let's talk about. So we talked kind of about the traditional approach, but I want to kind of give you an understanding of what it is that a coronary CT looks for, and kind of what the difference is and things like that between that and like the traditional approach and things like that. So what we do in the coronary CT is pretty much, it's a CT scan. It's a very simple test. You come in, you get an IB, a lot of the imaging is based on what your heart rate is doing, things like that. So you might need a beta blocker or something just for that procedure. And then you go into the scanner, they do a calcium score, quick one, and then they give you an injection of contrast where we can then see all of the arteries of your heart in a 3-dimensional image.
Correct.
And this is wonderful because you can see pretty much all the different types of plaque buildup in your heart, and if you have a stenosis or a blockage as well. Okay. And what we gather from this is that you can actually detect those mild plaque lesions that are missed on stress testing and things like that. The things that everybody would say, oh, you're perfectly fine. The lesions that have all this non-calcified plaque, which would be missed on a calcium score and all these different things, you can catch all of that stuff. And you can figure out that how much more at risk you are of actually having a heart attack or plaque rupture than somebody who has normal findings, And now at that point, you can really actually understand what kind of care someone needs. So like I've had patients who are in their, like a 70-year-old female with super high cholesterol, just got off the phone with her today, going over her test. She has no plaque in her heart, and she's 70 years old. I mean, her likelihood of dying from a heart attack is like extremely, extremely minimal.
Right.
So like I told her that, she's been scared her whole life because all of her doctors like, hey, you need a statin, you need this, you need that, you need all these different drugs. I told her, you don't need anything. Like I feel...
Keep doing what you're doing.
At your age, like now, if you were like 30 years old or 40 years old, maybe it'd be a different story. We'd have to discuss and talk and see what would, really what your biomarkers are and things. But at this point, you're at 70 years old and you have no plaque in your heart. Like you're not going to really, you haven't been shown, and she hasn't been on statin this whole time. You're not, developing plaque, versus like someone else, right, who's maybe in their 40s.
Yep.
And I've seen this over and over and over again, feel perfectly fine, super healthy, working out at the gym, doing all these different things. And they have significant plaque in their heart, soft plaque, hard plaque, all the different types of plaque.
Yep.
Okay. And that's where you can really intervene on these people and say that, look, we found this and now we found it early, but we can stop it. We can stop the progression now that we know about it. There's a great study out, that's been out of Europe, the long-term study, long-term data, we've had for a long time, where it showed that people who just get a coronary CT scan without even any targeted intervention afterwards, okay, they just get the scan, they have a 40% decrease in having a heart attack over a 5-year period.
Interesting. Yeah.
Why? Just because they know. Knowledge. Knowledge is power, right? We say that, just because you know that you have plaque in your heart, all of a sudden, what are you more likely to do? Eat better, sleep better, just exercise more, right? And if you need to take your medications, you'll actually be much more compliant with medications and things.
I want to point this out because what I'm hearing and what I've heard from you in the time I've known you is you're contrarian to the fact of, not that you don't care about cholesterol, because obviously you do, but it's about calcium. It's about the plaque, right?
Yeah.
About the plaque.
Yeah.
Because you've said that. It's like, I don't really care what your cholesterol is. I want to know your plaque, because it's the plaque that kills you. So that's a really interesting fact that some of you may be hearing. I want to make sure you catch that. I'm not saying, you have high or low cholesterol, that's good or bad, but Doc's saying it's the plaque that matters. And then distinguish again, because you did a great job in our consultation. We spent an hour in our consultation, you explaining when I was looking at my heart, 3-dimensional, about soft plaque and hard plaque, because you made a distinguishing factor of what's the more dangerous one. Can you talk about that?
Yeah. So I'm going to answer both of your things. Well, first off is, yes, I am a little contrarian to the norm. I was talking to one of my colleagues, like another cardiologist, and he was like, wait, so you're telling me that everything I learned for all these years that I was trained in, and he's a little bit older than me, but everything I learned and I was trained in all these years, you're telling me that my cholesterol and this and that, like if I went to any other doctor, they would just tell me, oh yeah, just continue kind of doing whatever you're doing and things like that. Don't worry, like everything's fine. Your cholesterol's just a little bit high. It's okay. But now you're telling me that I need to do more, because of what we found, Or you're telling me that, or in some patients, like I tell them, like, oh, like you need to do less for your patient because you don't want to harm. I always say, right, like we as physicians, we say do no harm, right? So if you're giving someone a medication that they don't need, right, you're causing probably some unnecessary side effects.
Sure, absolutely.
And so this is where I think we really kind of refine what we're doing by looking at an individual patient's heart, their individual risk, and going according to that. And so moving on to kind of your second question, because how do we identify that individual risk? It's we identify the different types of plaque in the heart.
Yep.
And it's very important. So everyone's heard getting a calcium score.
That's right.
And
that's the big buzzword now.
That's a big buzzword now. And I say we are way beyond calcium scores. I literally take calcium score, put it, I just put that to the side, okay? Because it's not about how much calcified plaque you have. What it's about is about how much non-calcified, the soft plaque. Because what happens is the soft plaque in your heart is the plaque that ruptures and causes a heart attack. The hard plaque actually does not. And what we know is that when you have calcium, the reason why calcium scores kind of became big is honestly, it's been around for years and years and years. Now people are just trying to, becoming aware of it. But really, like we should have been doing calcium scores 20 years ago.
Yep.
But now we're at a whole nother level where we should be going way beyond calcium scores. So a calcium score probably makes up for about 20% of your plaque. So if you have if you have a calcium score, of 100 or something like that, right? That's probably about only 20% of your total plaque volume. You probably have a lot of other plaques. So it's kind of, a calcium score may just be an initial test to be like, hey, okay, I might have some plaque in my heart. Okay. But it doesn't really tell me how much plaque total you have. And it doesn't tell me anything about the bad plaque.
Yeah, the soft plaque.
The soft plaque. Yeah.
So you don't even really care how much hard plaque is in there
Yeah.
because it's calcified. It's the soft plaque.
Actually, so the way that what I do now for patients really is that I actually want their calcium scores to go up.
You
know,
with hard plaque.
Yes, because what I want, what my approach is I take a patient, you know, and if we find plaque in their heart, you know, then we create a treatment plan based off of that, you know, and a lot of times if they have a lot of soft plaque in their heart and things like that, what I expect actually is that over time that soft plaque transforms to hard plaque, you know, and so what will happen? Their calcium score will start to go up. So it's a very poor marker. You know, I have some patients tell me that, I had a calcium score 5 years ago and it was like 300 and now it's like 700. I'm like, well, I don't really know what that means.
Yeah.
You know, it doesn't really matter to me because what is it? It could be that your plaque is actually becoming safer because you're on certain medications or certain diet and things like that that's actually helping you. Or it can mean that you actually have you're just having a lot of progression of your atherosclerotic disease. I don't really know. So like what AI actually helps with quite a bit, right, is it can help us measure all the different types of plaque. Right. And I always say, you know, there's a great saying by Henry Ford, you can't change what you can't measure. And you as a fitness, you know, coach, I'm sure you are very much aware of that, right? It's like, if you have these measurable benchmarks, right, it gives us these benchmarks, these numbers, calculated numbers that can tell me exactly how much plaque, how much soft plaque is there, how much high risk plaque, we call it low attenuation plaque, and how much calcified plaque there is. And then I can measure this over time and see that, hey, is this plaque getting better? Is it regressing? Is it transforming? What's happening? Or is it getting worse? And if it's getting worse, I know I need to up my therapy. If it's getting better, I know I'm on the right track, right? So it helps me as a clinician. It helps the patient, you know, and just the same way we measure our cholesterol levels, our blood sugar, you know, everyone's got these, monitors now, these glucose monitors and things like that. Same, we measure all these things. We should be measuring our plaque levels and the different types of plaque levels, you know? So this is where I think this is a game changer in the way that we can actually prevent heart attacks. And I really think, like right now, we say heart attacks the number one cause of death in the world. I think over time, you know, and we're doing, you know, research in this, our center's involved in clinical trials on screening patients and things like that. But I think over time, once this becomes something that we can detect early, then we'll be preventing heart. I think heart disease will end up becoming the 10th leading cause of death, you know?
And Dr. Parikh's going to be the leading physician, leading the cause here. Guys, you can see why I love him so much and why I've been enamored with this topic. I always have been. And Dr. Parikh serves as the director of cardiac CT and preventative cardiology at Image One and Cardiovascular Institute of San Diego. And when we met about 6 months ago and started talking about this, I really am enamored with it because of my health history with my family. And the more people I work with and train and coach as they get older, you start thinking, wait, I don't know what's on the inside. Right? Because traditional wisdom states, hey, what is your cholesterol? Right? And that's the thing is like the conversation is, hey, what's your cholesterol? What's your HDL? What's your LDL? And when I first started talking to you here at the gym and you were like, Todd, like, that's not, honestly, from a preventative standpoint, that's not the crucial aspect. It's the plaque. I'm like, well, how do I learn about the plaque? You're like, you got to get your tail in and get tested so that I can see it. And when I saw it, I'm like, I have never seen this before. And guys, I'll post my results, at least some of them, because I'm living to 110 and Dr. Parikh has taken a personal responsibility that I'm around so I can so I can do this, my man. I mean, this is really, really good stuff. And we'll talk more later on if you want, regardless of where you live around the country, around the world. Where the heck can you get tested? Where do you get tested for this stuff? And you think about the investment, it's not that much when you think about the return. I don't want a heart attack. No one wants a heart attack. And the number one leading cause of death here in the U.S. is heart disease. So really important. Anything else on the soft plaque? Because I just enamored with. I never had heard of that until you showed me.
Yeah.
Just a couple little smidlens of soft plaque in my area. Like that's the stuff that can break off and clog you up and cause a massive heart attack.
Yeah. I mean, I think I think going back to this like notion of calcium scores, I think people sometimes say, I just had a case last week, and just think about it off the top of my head, patients in their 70s, and they have a calcium score of 0. You would expect someone in their 70s have a calcium score of 0, they should be perfectly fine. But lo and behold, he has in his widowmaker artery, he has a 50 to 69% stenosis blockage, And not only that, that plaque is actually, the other thing we can see on that is we look for something called high-risk features of plaque. So we can see body calcification, or positive remodeling. These are all things that we can see on the CT scan. And now I know that this patient, again, very healthy, a very healthy guy, traveling all over the place, really living like his best, probably like semi-retired life because he's doing a lot of work and things like that. But he is, has no other plaque anywhere else in the heart, but just that one place. And we caught that now, He luckily doesn't need a stent because there's good enough flow through that, and AI can measure that too, can measure flow through the arteries. And so he doesn't need a stent, but now that we found this, we're going to treat him pretty aggressively medically. And I think, his dad had a heart attack in the past.
Yeah.
I think we can definitely prevent him from having a heart attack just by now we're aware, getting him on the right medications, the right protocols and things like that, and boom.
And the medications will clear that.
So very interesting. I mean, again, I think the one of the big things, right, is the question is right, okay, you get this test done, right? You get all this data from AI.
Yep. It's extensive.
Stuff,
I love
right?
By the way, I love the report I got. It was awesome.
Wonderful. Yeah. Thank you. But, I think you get all of this data. Then it's like, well, what do we do with this? And I'll tell you, like, you take that to another doctor or something like that, and they're gonna be like, I don't know what to do with this, because it's not mainstream yet, unfortunately. And it will over time, hopefully this is what we need to do. We need to make it mainstream. But right now it's interpreting, I think, AI data, and all of this stuff that you get, and then coming up with a plan for it. There's very few people in the country right now, I think, that are really specialized in this and can really kind of help patients understand what it means and also come up with a plan on what to do with it. Okay. Yeah. So, so like for someone like him, like we found this lesion, right? There's different medications that we know will kind of help reduce the plaque burden or transform the plaque, okay? So everyone talks about statins, and yes, statins, I know statins are helpful, actually. There's clinical trials showing that statins can actually transform the plaque from the soft plaque to a more calcified, stable plaque. Then there's newer medications, which are much more targeted. I really like these ones. They're called PCSK9 inhibitors, okay? And these medications can really give a profound decrease in your cholesterol level, and they don't really cause these muscle cramps that people get and these other issues that people have, because they very much, they work in the liver where cholesterol is processed and things like that. And what it does, it just increases the uptake of the LDL bad cholesterol that's floating in your bloodstream and things like that. That's causing all of this plaque progression and things like that. It's just uptakes that more. So it's kind of, you're just decreasing the fuel, to that plaque. And so, these medications are actually very effective. And what we're seeing is that, again, they help transform that plaque into a more calcified plaque, but in many cases, they also help regress that plaque. Now, we don't have huge clinical trials on this yet, but we are seeing some regression in plaque from these medications. And that really is becoming kind of the holy grail, if you can actually detect that you have some plaque early, and then you can actually reverse that plaque, I mean, that's huge,
Is there a correlation between LDL and the plaque level? Like the higher your LDL, you're probably going to have more plaque, or is it inconclusive?
So that's a great question. We know that lower LDL cholesterol levels decrease your risk of having a heart attack. And that is population-wide, right? These are population-based studies and things like that. But like I said, what I'm seeing, we've done probably over 1,500 cardiac scans in 6 months, maybe even more, maybe 2,000 cardiac scans in just 6 months. And what I'm seeing just at our center is that the correlation is not great. I see a lot of people who have high cholesterol, but they don't have that much plaque in their heart. I mean, I'm talking about familial hyperlipidemia, like high cholesterol to the point, of like LDLs over 200. It's a genetic problem, and they don't have that much plaque in their heart.
Wow. Versus
some people who have normal cholesterol levels. What someone would say, you take it to a regular doctor and they'd be like, oh, your cholesterol's all right, you don't need anything, you're fine. You feel fine, you don't need anything, and they have significant plaque buildup in their heart.
Mm-hmm.
And so really, yes, is there probably an overall correlation? Yes, but why are we treating people just on this population-based level when we can really personalize the therapy?
Yeah.
What is it for you? Why does it? Because we know so many other factors go into it. There's genetic factors. There's it's not just cholesterol. There's genetic factors. There's probably inflammation factors. There's insulin resistance, high blood pressure, all these other factors that are going into it as well. So I think that there's so many.
Those 4 pillars, like stress, right? The inflammatory aspect. This is, I guess, the $1 million question, because you got so much focus and emphasis on plaque.
Yeah.
But what causes the plaque in the heart?
Yeah.
Like if that's the key.
Yeah.
How do we get to what causes the plaque in the heart so that we can prevent the buildup of plaque?
The buildup of plaque. Yeah. I think. I mean, obviously, yes, lowering our cholesterol, because we know. So, what you have, your coronary arteries, which are tiny. They're like 2 to 3 millimeters big. And so they're very small, and you have every beat you have blood flowing through them, right?
Mm-hmm.
And you have an endothelial layer, which is the inside layer, and then you have your and that's built up of a bunch of cells and things like that. But when you have you have a breakdown in that endothelial layer, and that usually comes by some type of stress to that to that tissue, right? Once you have a little breakdown there, then that becomes a nidus for cholesterol to start building up in there, and then you have different things, macrophages and all these other different immune system. It kind of gets in there and starts attacking it and things like that. And you have all these problems. And then that's what creates that plaque there, and then the progression of plaque. And how plaque starts is it's soft plaque, and then over time, it becomes calcified, and then we see calcified plaque, but the calcified plaque becomes safe. The soft plaque becomes more at risk of rupturing and things like that.
Yep. Interesting.
So
it's interesting.
Yeah. And so yes, do we know that when you have higher cholesterol levels, you're more at risk because you have that fuel to kind of get in there.
Correct.
But some people, like I'm saying, they just don't produce plaque.
Yeah.
Well,
that's what, I got tested, and that was just really interesting to see inside the heart and see the actual, you were like, well, you're good here. A little bit of plaque buildup here, and what's really important is this for me. It's like, okay, I have a baseline now.
Yeah.
Like, I'm not worried about now, but in 5 years, or let's say get tested what I want to get tested in 2 or 3 years from now, get tested. Is it the same, better, or worse?
Exactly.
If it's worse, we got to be more aggressive with our treatment of that. And then, you continue on that. And I think that's what really is intriguing to me. I do want to talk about biomarkers, because the other big thing when we talk about biohacking, and we're always trying to figure out, how do we maximize our health? Are biomarkers important? There's all these different blood tests. You can have 150 biomarkers done. Compare it to a heart scan or not? What are your thoughts on biomarkers?
Yeah, I think that's a great question. And yes, biomarkers are helpful. And at the same time, I don't care about them until I have a scan of your heart. That's the reality of it.
Ideally, you do both.
Yeah.
Scan the heart, Get the biomarkers because
So everyone gets biomarkers first. I say get a scan of your heart first.
Yeah.
Right? Because, like I said, I don't really care what your biomarkers are until I know whether or not you have plaque in your heart.
Right.
Now, depends on the age as well. Okay. Now, I remember you asked about this. At what age should I start getting scanned and things like that? I mean, there's absolutely, like, in the current medical system, medicine 2.0, right? And this is like, now everyone's talking about medicine 3.0, right? Where it's like,
would you say that's 3.0?
Oh, for sure.
Yeah.
This is the best 3.0 that you can do for your heart, because this is you looking, and this is why, insurances and the medical system don't support this yet, and like right now, like we screen for cancer, right? Like you don't have any symptoms.
Yep.
You go and get a colonoscopy done. You go get a mammogram done. You go get all these things done, right? You have no symptoms, right?
Good.
And guess how long that took? It took almost like, like mammography was like founded like probably 20, 30 years before it actually became screening all over, the U.S., right? So are you going to wait? So this is like just coming out now and we have all this stuff. Are you going to wait 20, 30 years for the guidelines?
I want to be a spokesperson for the American Heart Association to do this. To do this. I should be a spokesperson, seriously, because receiving this treatment from you and your staff, I can't imagine not doing it. If you're like 40, start getting your heart scan, unless you have some crazy family history, but get the baseline at least, and then track it. I do like the biomarkers, and you had mentioned, I remember, a few different biomarkers. When you get the test, you may need to go to an outside company to get some of the deeper testing that sometimes traditional medicine may not test
for sure. No, there's some advanced biomarkers that I do like and I do follow. I mean, I think everyone should have a lipoprotein little a checked. That's what is it? Lipoprotein little a.
Little a.
Yes. Yep. It is a marker of, it's a we call it an LDL-like particle. Okay. But it, in and of itself, is an independent risk factor. About 1 in 5 Americans have this. It's a genetic thing. And so if you have a family history especially, you should definitely have this checked, okay? And it can increase, depending on what your level is, it can increase your risk factor of having a heart attack. Even if you have normal cholesterol, normal everything else, increase your risk of having a heart attack by 3 to 4 times fold than the normal population.
Wow.
So, and that's genetic. And we don't even have a medicine for this yet, but there are some medications coming out for it, in the near future, things like that. But so I would always get one of those checked, lipoprotein little a. And I think at this point, even the American College of Cardiology is recommending a one-time check for everyone in their life, at least a one-time check, because it's either going to be high or low. It's genetic,
But if you go to a doctor and ask for that, they're going to look at you and say, no, right?
They may. It's becoming a little bit more known. Okay. So that part's good. You should ask for it, and they should be able to order for you, but it's not going to be on your standard physical and things like that.
Yeah, I'm fortunate. I got a great primary that is so just open-minded to all of this preventative side of things and is agreeable, and I love them for this. But in the past, it always hasn't been easy. I've had between the naturopathic doctors and outside companies to do this. Yeah, that's interesting.
The other thing is apolipoprotein B. You should get an apolipoprotein B level checked, because that is a marker of all of we call it atherogenic particles, meaning the cholesterol particles that are actually dangerous and going to promote plaque buildup in the heart. That's what an ApoB. So
what's it called?
Apolipoprotein B level.
Okay.
Yeah.
I'll put that in the show notes, folks. Well, I like this. This is getting good medical terms here.
And then there's LDL and LDL particle number. I think LDL particle number is good too, because you kind of get a better idea of whether your LDL is, the small LDL particles that are actually, going to get in between in between your arteries and clog it up and things like that, But I think really, I think for cholesterol wise, I think apolipoprotein B and lipoprotein